Hi everyone, welcome to the antivirals lecture. This lecture is going to focus on a couple of the more common viral syndromes that you'll probably see across multiple aspects of medicine. The more specialty viral syndromes such as HIV and the hepatitis A, B, and C treatments are going to be hopefully covered by a colleague of mine in a separate lecture. And those won't be testable because they're very specialty and you won't really need to know them unless you actually work in that specific area. But it's good to be able to recognize the drugs and what they're used for in case you're ever meeting with a patient, you notice something on their med list and you're like, oh, what is this? And being able to recognize an HIV med off the top is pretty handy. And there are some applications that are more general, such as PrEP, which hopefully George will talk about a little bit. And then it's things like post-exposure prophylaxis for healthcare employees, which is something that anyone could maybe deal with at any given time. So that stuff is more broadly applicable to what we're talking about here today. But I'm going to leave it to him, and hopefully we're going to get him in. He's having a bit of a family emergency right now, so hopefully we can schedule him for later in the semester. So it might not jive correctly with the course sequencing, but I hope to get him in because he's an interesting speaker. And I think even recorded, he'll be entertaining for you guys and be worth a listen either way, just to get the baseline knowledge on HIV. So anyway, I'm going to talk about a couple non-HIV hepatitis related viruses quickly today. So the first is herpes simplex virus. So there's a lot of different types of herpes viruses, and the ones we think of commonly are all kind of stratified into different types, and they're treated somewhat similarly, but also somewhat differently. Herpes viruses generally infect skin cells and nerve endings, and they're characterized by neurovirulence, latency, and reactivation. So they live in the nervous system, and a lot of people might get exposed to these at different parts of their life. But for most of us, we don't ever really have any actual physical manifestation of the illness. For example, here's a good stat. So some of this stuff I stole from George. So the funny backstory, I used to do the whole virus lecture, including HIV, and my buddy George gave me grief for teaching HIV when he's an expert and he's a friend of mine. So I brought him in and he took my slides and modified them, and so now I'm taking his slides that he took from me and I'm remodifying them. So some of this stuff is George's, so some of these comments are kind of funny, but up to 95% of prostitutes have HSV2 compared to 3% of nuns. So there's an interesting stat for you. I don't know where he got that. I feel like that sounds made up to me, but if you want to look that up, be my guest. So the idea here is that the common two types of herpes that we probably think about that are either sexually transmitted or transmitted by contact, you can simply think about it that way, HSV1, HSV2. Historically, HSV1 has been the above the waist herpes, which is more of a cold sore presentation. So this is something most people get on their mouth. And HSV2 would be the cold sores that happened on the genital region. Now, you can have either one in either area. They're basically the same thing. They're very slightly different strains, but they do essentially the exact same thing. Versus, types 3 through 7 are all quite a bit different from type 1 and 2. So type 1 and 2, think about them as basically the same thing. And I don't care if you know which one's top or bottom. You're gonna see the if somebody ever gets a herpes test, you're going to see both 1 and type 2 come up in different types for different swab samples. So you might see 1 for a genital swab and 2 for a mouth swab, and I wouldn't be surprised. The treatment doesn't change, and again, it's pretty much the exact same thing. As far as HSV infections, most people actually do have some exposure to HSV type 1 or 2. Whether it's because they were kissed as a baby or it was transmitted to them somehow at some point. Most of us actually have had some exposure to it. So a lot of people have antibodies built up to HSV 1 and or 2, and that can help with different infections. Now, certainly there are people who get recurrent cold sores or recurrent genital herpes as well, but the good news about this is that most people who get an initial presentation of a cold sore or genital herpes, that outbreak, the first one, will be the worst. Subsequent outbreaks are usually less severe and don't last as long. And a lot of people won't, after they have their first outbreak, won't ever get another one. The people that do get recurrent ones, they usually, again, diminish over time, and ultimately the body is able to react faster to those recurrences. Now, people will get reactivation of herpes viruses from things like stress or exposure to cold weather. Can do it sometimes too. There's other things as well that can possibly trigger them, but for the most part, people who get them, unfortunately, it is going to be. You think about this as a virus that sticks with you for life, and that's basically true. But at the same time, for most people, they don't really have complications throughout the rest of their life. It's usually 1, 2, maybe 3 outbreaks, but it definitely diminishes over time how frequently those outbreaks happen and how severe they are. The other types of HSV are on this other side of the slide, and you have type 3 here, which is actually varicella zoster. So this is the type of herpes virus that causes chickenpox or shingles. Type 4 is Epstein-Barr, which is mono. Type 5 is cytomegalovirus, which usually just happens in HIV immunocompromised patients. Sometimes they see it in really little neonates too, which would kind of fall under the immunocompromised thing. HSV types 6 and 7 can cause roseola, which is a fever, skin rash in children. And type 7 can also cause something called Kaposi's sarcoma, which is usually something only seen in HIV patients who have autoimmune deficiency or AIDS. And it's quite rare in any other type of population. It's usually advanced AIDS that has at some point your immune system is shut down so much that this virus is opportunistic in that situation. For people with functioning immune systems, or even somewhat suppressed immune systems, like if we pharmacologically suppress somebody, they probably aren't going to get Kaposi's sarcoma. That's really a heavily associated HIV related type virus. Okay, so how do we treat these viruses? They're all pretty much targeted with the same types of drugs, and there's really one that you have to remember for my class. I don't care too much about the rest of this stuff, which is nice. And that one is technically 2 drugs, but really they're the same thing. So Acyclovir, and that's what this drawing is showing you, how an HSV infected cell. So Acyclovir works intracellularly to prevent the replication of the herpes virus. So it essentially interjects itself into the replication process, so the virus can't replicate as much. Famciclovir is sort of an alternative, and Valacyclovir is just a type of acyclovir that's different in the way it absorbs into the body, and I'll talk about that here in a second. There are some other options that I don't really care about. You might, for instance, like to know this in certain aspects of your practice potentially. There is a ophthalmic preparation, so there is an eye drop that works for HSV, and a docosanol, is the topical product of Breva, which we'll talk about here in a second. So those ones are a little more common. But acyclovir is the big drug to remember here. It has good activity against both herpes 1, 2, and varicella zoster. It doesn't have great activity against Epstein-Barr, CMV, or HSV6, so we kind of use different stuff for those. It, again, inhibits viral DNA synthesis by inserting itself into the replication process, aka being a chain terminator. It is the only IV HSV agent. So if you have somebody, what we call aseptic meningitis, where they get a herpes simplex virus in their central nervous system, that is the only drug we can use to treat it. So acyclovir is really important from a critical illness perspective as a IV antiviral. It does have really good CNS penetration. The problem is it's got a really short half-life. It doesn't last very long, so you're usually getting 3 to 5 times a day for dosing. Therapeutic role, again, I just talked about the aseptic meningitis for IV therapy. You wouldn't use oral for that, by the way. For oral or genital herpes, chickenpox, you could use it, but because it's dosed so many times a day, we usually use Valacyclovir, which I'll talk about here in a second. It's generally safe in pregnancy, category B. We haven't talked about pregnancy categories yet, but A is the best. Very few drugs are A. A means that we've actually tested the drug in a group of pregnant patients, and it's been found to be effective. So again, very, very few drugs are like that because we don't test a lot in pregnant patients due to ethical issues. And then B, and the further it down it goes, means basically the less evidence we have, and usually you're looking at animal models. So a category B might say that, well, they tested it in pregnant animals and the animals didn't have any malformation. So, or there might be case reports in humans, or maybe they didn't test it in humans during the initial clinical trial, but enough pregnant patients have taken it that they've retrospectively looked at it and found that it's been safe. So category B is usually pretty good. It means that there's low risk to take it. There's not a whole lot of side effects with acyclovir. It's generally a really well-tolerated medication, but they can lead to renal stones, especially with high dosing in the IV formulation. But that's really the only side effect that's noticeable with this medication. Valacyclovir is the L-ester of acyclovir. So the nice thing about this medication is it's basically, so this medication first and foremost is acyclovir. That's what the active drug is. There's nothing different about what we just talked about, but the product is formulated so that it's got better bioavailability. So if you take a pill that's just plain acyclovir, you don't absorb very much from the GI tract, whereas the valacyclovir actually rapidly absorbs much quicker. But once it gets into the body, it's converted by the liver into acyclovir fairly quickly. So you aren't changing the type of drug, you're just changing the amount that you can get in through the GI tract. So that's where this drug comes in handy. So your serum concentrations are much, much higher than if you took oral acyclovir plain. It's usually dosed once to 3 times a day, depending on what you're trying to treat. So like if you have somebody who's got their first oral or genital herpes outbreak, you're probably going to look at a BID or a TID regimen. If you're using suppressive therapy, some people might take it chronically for different reasons. Maybe they're immunocompromised or whatever it might be, but sometimes you might see once daily regimens for that. And that's what I've got here as well. So, but this is your drug of choice. So if you're ever going to prescribe this for somebody who's got a cold sore or a genital herpes outbreak, you're always going to pick valacyclovir. Don't prescribe acyclovir because, again, this is the same drug. It's more bioavailable. It's the same side effects. There's nothing different about it. It's just much more convenient for patients to take this. Valtrex used to be brand and expensive, but it's been generic for quite a while now, and so it's relatively cheap. And again, just like acyclovir, it's very well tolerated overall. The one thing to also remember is this final second to last bullet point. This is not IV, so you can't give this product IV. It doesn't really make any sense why you would, because the whole point of this product is to get better bioavailability for the oral route. So IV is not an option for valacyclovir. The additional agents, I said I wasn't really concerned you know these, and I'm not going to test you on famciclovir or penciclovir. Docosanol Abreva is probably something worth knowing. It's the over-the-counter topical product. It can shorten healing time of oral lesions by 1 day. The earlier you start this, the better. So a lot of people who get cold sores can feel them coming on in advance. And so if you start it early while you can feel that cold sore, once the cold sore has broken skin, it's probably not super effective, but it does work if you start it early, and it can shorten the duration, which a day doesn't sound like much, but if you have a cold sore on your face, a day probably is something you're willing to pay 15 or 20 bucks for the Abreva. So that's really the only topical product that's active against HSV that we use regularly. There are some topical acyclovirs and things like that. I'm not going to go into those. We can talk about those a little bit more during dermatology. I just wanted to point this one out now. It's a pretty common application of this. The famciclovir is a bit more broad spectrum of an option. So for Epstein-Barr, it's also used for hepatitis B, and similar to our other drugs as far as how it works, just a little more effective for those other types of HSV viruses. Okay, moving on to influenza. So influenza affects about 20 to 50 million individuals annually. Cost in the US alone is about $37 billion. So this is, of course, something that comes up seasonally and lasts usually throughout the winter and into the spring. It's something we vaccinate for early in the fall. And we try and predict which subtypes we're going to get based on what else the world is experiencing in their flu seasons, but it's always difficult. Usually the flu vaccine, I feel like, kind of falls anywhere from 50 to 75% efficacy, which is much better than nothing, but it's still not it's hard to convince the public of something like that. Oh, it's only a 50% chance it works. What's the point in getting it? Well, there's actually a lot of good reasons for getting it, even though it might not actually prevent the flu completely. So people who are really high risk should always consider influenza vaccine. Everyone should, but these are the patients you should really harp on. So age greater than 65, less than 2, pregnant patients, people with severe heart or lung disease, and immunosuppressed patients. There's really no contraindications to the flu vaccine. We give it to 6 months olds. We give it to all the people listed here. There are a couple formulations we might not give, and I'll talk about that in a second. Influenza A and B are the most common, and they use H and M N type, like H1N1, for example. These are the abbreviations for hemagglutinin and neuraminidase, which are the surface proteins on the influenza capsule. And then the epidemiologists use something called antigenic drift, which is studying how the virus changes year to year. It's kind of interesting that this virus moves around and it shifts and its proteins change and all that stuff. So it's kind of cool. But at the end of the day, I'm not going to go into it too much for this course. A little bit beyond our scope. Focus on the drugs. The transmission is respiratory droplets. Incubation period is about 2 days, so it's got a pretty fast onset once you've been exposed to it, in contrast to the current COVID-19 experience we've got. Symptoms, so again, rapid onset, headache, fever, muscle pain, non-productive cough, and sore throat. One thing I always like to point out with this is that most people who get influenza don't have GI-related symptoms. I think the general public often thinks of the flu as being something, oh, I got the flu last year. I was, vomiting and had diarrhea for 3 days straight. Well, that's probably not influenza. That was probably some sort of a stomach virus or a stomach bacteria or something like that you got. So a lot of people say, oh, I got the stomach flu or a stomach bug or something like that, and it just gets confused with influenza. Influenza is much different, and again, generally doesn't really have GI related. Certainly, it's possible to have a GI related symptoms as well, but it's just not a core symptom that you're going to see with influenza. So that's one important differentiating factor. Can it lead to pneumonia after infection is complete? Yes, this is probably the biggest risk factor when it comes to why the flu is deadly for people. So a lot of times people will get a streptococcus pneumonia, or George here has classically it's an MRSA pneumonia. Either one is not a good situation to be in, but a lot of times because of the inflammation and the way the virus attacks the lungs, you're putting yourself at higher risk to get a situation where bacteria can get in and proliferate more, causing a pneumonia. So people who die of influenza don't die because they have influenza. They die because they have a pneumonia that's on top of their influenza, and it's very hard to treat at that point. For example, like a really nasty strep pneumonia can release lots of toxins into the body, and so sometimes we'll see people on renal replacement protocols to try and get that stuff out, filter it out. But for the most part, influenza can be prevented and treated in the vast majority of patients, but there are those few that will go on to have severe complications like a pneumonia. Influenza prevention. So again, the vaccine is really the biggest weapon we have against influenza. After that, our treatment choices are not great, but what people will get is the IM or intranasal vaccine. There's two different options. The big difference here is the intranasal is a live attenuated vaccine, and the IM is not. Live attenuated vaccines, the one thing to remember about them, we haven't talked about vaccines yet. We'll talk about those more during pediatrics next summer. But the big thing about a live attenuated vaccine is that it is not indicated for patients who are immunocompromised. So we don't give them to pregnant patients. We don't give them to HIV patients. We don't give them to people who are on chronic suppressive therapy for organ transplant. It's just not something we do. So at a minimum, you're looking at about a 50% reduction in influenza development, and again, up to 70% reduction in hospitalizations. So that's usually what we see on a yearly basis. Ideally, everyone's going to get a flu vaccine by about October, and you're going to decrease the spread significantly. However, because a lot of people don't think they need it or don't believe in vaccines or whatever reason, the flu vaccine seems like most people are okay with vaccines that they get, like a couple shots of, and then they're good for life. That's fine. But when the yearly flu vaccine always seems like it's somewhat of a battle to get people to do. And there's a lot of people that just simply choose not to for whatever personal reasons they have, which I mostly strongly disagree with, but it's not worth talking about at this time. The point is that this is a significant way to prevent disease in our population, and certainly in our more vulnerable populations as well. And that's the big concept of herd immunity. So you have lots of people, let's say you have 100 people in a room, if 50% of them have the flu vaccine and somebody comes in with influenza, that influenza can move amongst those people who aren't vaccinated a lot easier than it could if 80% of that room or 95% of that room was vaccinated. Then it's much more difficult to get to those few people who aren't, because there's no vector sources that it can take hold in, or no host sources it can take hold in. So that's again, kind of the basic concepts of the vaccine and why it's really important to get it. I think a lot of people, again, are healthy and they say, I've never gotten the flu, I'm not going to get the vaccine. Or the last time I got I hear this a lot too. Oh, whenever I get the flu shot, it gives me the flu. Well, that's not actually possible. Even if you take the live attenuated nasal spray, you're still not going to get the flu. You might get like a weakened version of it. Some people will feel their immune system ramp up a little bit during it, so they might feel a little bit sick, but that's not the flu. It's very different. So that's one thing to educate people on. It's actually not possible, especially if you're giving the IM shot, to get influenza from that. That there's no way that that's scientifically possible. So that's something that, again, we can try and educate on as health providers, but some people won't ever believe that because that one time they got the flu shot and they got really sick. So there's that. The one big contraindication to the flu shot is egg allergies. So most vaccines are made using sort of some of the proteins in egg whites to as a medium type thing. And so there are some issues with people who have egg intolerances and egg allergies. There is an egg-free product out there called Flu Block, which is available in most places that are giving flu shots. So that's something that even our egg allergy patients and friends and family can still qualify to get a vaccine. If you do have questions about like, oh, this patient's immunocompromised, are you sure they can get it, or they're sick, they currently have a fever, should they get it? The CDC is the best website, best resource for all that stuff, and they'll have very specific guidelines for when to give, when not to give, who to give it to, what age, what time, et cetera, et cetera. All right, let's talk about a couple drugs used for influenza. There's neuraminidase inhibitors, excuse me. So these drugs, what they do is they alter the viral particle aggregation to each other in cells. They have activity against both influenza A and B, and they prevent the spread of influenza within the body is essentially what they're doing. So it doesn't prevent the replication, but it prevents it from moving around in the body, which can prevent symptoms overall and can make the flu last a little bit, the duration a little bit shorter. The major drug that we've probably heard of, and it's used. It's called Tamiflu, or oseltamivir is the generic name of it. It is generically available now, so it's relatively inexpensive compared to what it used to be. It's an oral capsule, and it also comes as a liquid suspension, which is really helpful for pediatric dosing because the doses are weight-based, and oftentimes it's not a clean number that you're giving somebody. So, but for adults, you're looking at 75 milligrams twice daily for 5 days. It's a short course. Early administration is critical. After 48 hours, there's really no point in giving this medication. It's not going to help, so you really have to get it in before that time frame. Usually what clinical trials are showing, people are getting about a day less symptoms once they take, if they take the full course of Tamiflu, which again, in the grand scheme of things, you're like a day. So if you're having flu symptoms for 7 to 10 days and it's instead of 7 to 10, it's 6 to 9. Well, what's that mean? Well, that's one more day that person can go back into work and doesn't have to use vacation or sick leave. It's one more day they don't feel like, they can't get out of bed. So it actually does make a pretty big difference. I think that's one thing that I used to think, wow, it's one day. Is it really, why are we giving this all out? And, for that person who's sick at that time, a day does make a pretty big difference. So keep that in mind when you're prescribing these, that this is an appropriate medication to use, especially if, you have somebody who's presenting within the right time frame. If somebody's 3-4 days into the flu, it's really not worth it unless they're, they could maybe be, sometimes patients can maybe try and persuade you to do things that you don't want to do, but at that point it's really not worth prescribing and wasting the money. Severity and the secondary complications do diminish usually, so even if the person's flu, maybe they don't get a full extra day out of it, but their symptoms should be a little bit better. They should feel better throughout the duration of the illness. It's approved in anyone over 1 year old, and they do use it in kids younger than that, actually. So there's recommendations for neonates because there's really not much else out there for this particular product. It's really the only one. There is this alternative called Relenza, which is an inhaled product. I don't ever see this dispensed. I think when it first came out, it got kind of popular, but they're shown that it has some lung. It can exacerbate asthma exacerbate. It can trigger asthma exacerbations. It can cause COPD to patients to have worse symptoms, and it's not indicated for a really young kid, so it's very rarely used. Most people at the end of the day are going to much rather prefer to take oral medications over using this inhaler. But the idea was when they developed it as well, let's get to the site of action. It might act quicker, and actually it doesn't. It doesn't work any faster than the oral product does. There is one newer drug for influenza that came out last year. It's called Valacyclovir or Xofluza. And what it does is it inhibits a subunit of the viral polymerase, so it ends the replication sequence. So instead of preventing the virus from being able to go in different parts of the body like Tamiflu does, or oseltamivir does, this drug prevents is a chain terminator, so it prevents replication of the virus. So it's a little bit probably better of a mechanism. It's going to be more active of strains resistant or strains that have already taken hold. It is a PO med just like the other ones. And again, the benefit is actually shown to be much better when you start it within 24 hours of symptoms. So this one should be done a little bit quicker. I don't know what the recommendations are if you still prescribe it. It's still kind of new. And honestly, I haven't seen it used very often, so maybe we'll see more information with that. It does shorten symptoms by about 1 day, just like Tamiflu. There might be some logic to using Tamiflu in combination with this at some point, but again, we aren't there. This drug's too new, and I'm sure there's ongoing studies looking at that type of stuff, but at this point, we haven't really come to a conclusion on that. But they do work differently, and they could together maybe be a bit more effective than by themselves. One thing this drug does is, compared to oseltamivir, is it rapidly decreases concentration of virus in respiratory secretions. And that might be relevant as it might prevent the spread more so than a neuraminidase inhibitor. So if you already have the virus in your lungs and your respiratory tract, it's not going to prevent that from being, oseltamivir is not going to prevent that from being there. Valacyclovir will. So that's what's causing the spread when you cough or wipe your snotty nose and touch a doorknob or something like that. That's going to be the reason why this virus spreads around. So that's one way that maybe in the future we might use this more, because it might diminish the transmission of the drug more, or transmission of the virus. Adamantanes are a group of drugs that aren't used very often at all. They aren't really endorsed by anyone anymore because they're pretty much resistant to H1N1 and even some other variants. Where they used to use these a lot is in nursing home outbreaks. They would give people amantadine because it was cheap, and it usually worked for strains like that. And that's kind of fallen out of favor. You might see it done still here and there, depending on if they know what specific strain. So if they can isolate, well, we know this year, it's this HN strain, and amantadine actually has activity against that. Amantadine is an old, cheap drug that's pretty well tolerated. So in that case, it might be, if you have to, prophylax 100 residents, maybe it makes sense to use something like that to, save a few bucks. But now that oseltamivir has come down in price quite a bit, it's kind of a moot point. So they're just going to use Tamiflu in most cases. I thought I'd just put this on here sort of as a historical thing, but it's really not used very often anymore. HPV, I don't have much to say. There's a Gardasil vaccine, and there's another one that's more strains, which I'm blanking on the name of it. But there are a couple vaccines out there that prevent this, which hopefully, if we continue to vaccinate our younger populations against these, we'll start to see some of these strains disappear from the adult population. But the HPV viruses are human papilloma viruses are responsible for common skin warts. The more problematic ones are the genital perianal warts that can cause lesions in areas obviously we don't want them to be and are difficult to get rid of and treat in those spots. And then there's cervical, penile, and oral throat cancer, which are type 16 and 18. So there's a couple other strains that are problematic too, but those are the big four, and that's what the Gardasil vaccine, which came out, covers. And again, there's another one that has a few more strains that it covers. There's a topical product called imiquimod or Aldera, which modulates the immune system and helps treat the virus topically. It does take a really long time to use. You have to apply it 3 times per week for have 6 to 10 hours of contact time, and continue for about 16 weeks total for clearance. So it's a really long course, and obviously not the most convenient thing to have to apply and have to keep on and not worry about it rubbing off or something. So there's a lot of issues with that. So the vaccine certainly is going to be the best bet going forward, but know that there is a topical treatment for it that could be used. All right, COVID. I wanted to talk a little bit about COVID just because it's of course, quite relevant right now. And there's not much to say. I just wanted to cover some of the current things we're doing, and then what we've tried or what we've thought. There was a frenzy of activity around treatments in early spring of 2020, when there was a lot of ideas as to what was perpetuating the virus, and what should be used, what shouldn't be used, what was maybe some early correlations people were seeing that for the most part didn't really amount to much. But basically, for treating a COVID patient, we're looking at, it's very similar to treating influenza. You're looking at standard supportive care, making sure their breathing, cardiovascular systems are appropriately managed, and then antimicrobial prophylaxis or treatment in the case if they have a community-acquired pneumonia. It's going to be the same thing that people who have influenza are going to experience, as they might have a pneumonia, bacterial pneumonia, on top of their respiratory viral infection. You want to make sure you continue to treat other chronic conditions. Things like uncontrolled diabetes, hypertension, other cardiovascular diseases can put people at higher risk for complications. So making sure we're managing those at the same time. The only drug out there, there's only really 2 drugs that have been shown to be somewhat mostly effective for COVID patients, and they are glucocorticoids, which we'll talk about in an upcoming lecture. Glucocorticoids basically just work as a broad spectrum anti-inflammatory, and they supplement your body's endogenous ability to produce cortisol, which is a stress steroid response. But dexamethasone is one of the more potent ones, and that's a popular choice for patients who are on ventilators and have high oxygen requirements. It's generally recommended to give those patients glucocorticoids. The other drug that is new is kind of new, is remdesivir or Veklury. This was a compound in development by the company Gilead. Gilead makes basically every major antiviral is made by Gilead. They make all the big HIV drugs, all the big Hep C drugs. That's sort of their thing. And I believe they developed remdesivir in response to some of the older types of SARS viruses. And it never really needed, those virus outbreaks sort of ran their course before remdesivir was really needed. And now we're in a situation where it was needed. So they brought it to market relatively quickly, for compassionate use, and so people could apply to get it, and the government was footing the bill for a while there, and now it's actually a marketed product sold by Gilead. So Gilead's now selling remdesivir and has upscaled their production massively. So it's a lot easier to get now, where before you kind of had to make some hard decisions where we had lots of pretty strict criteria on what you could and couldn't qualify for if you were looking at putting a patient on remdesivir. But usually it's somebody who's requiring low flow oxygen or worse, so if they're ventilated, or high flow oxygen or something like that. Of course, they'd qualify as well. Not always available. I said, this has been a popular drug since it's come out, because it's really the only thing out there that's different from what we do for other things. It's the only thing out there that hospitals wouldn't have already had on hand to treat COVID. So that's a big change there, and that's why it's going to be probably a little bit give and take throughout the rest of this epidemic. Mechanism, what it does is it's a chain terminator, so the mechanism's there. There's also, I just put this at the very bottom, there's also some immunotherapies out there. People are looking at using plasma of patients who have already had COVID and been cured of it, or it's run through their system or something, so they've built antibodies to it. So treating those patients with existing infections with plasma from those patients, giving them the antibodies they might need to fight the infection off. A couple other things briefly. NSAIDs are non-steroidal anti-inflammatory drugs. These are medications like ibuprofen, naproxen. They're really common over-the-counter pain medications. There was a controversy at the beginning where there are a few case reports that came in early during the epidemic, where there are some younger patients that passed away due to COVID-related complications, and it was linked. They thought there was maybe something to do with them because they all had in common they took ibuprofen or naproxen or some other NSAID. Subsequent studies have shown that that's not really true, and we don't really see any increased risk. So generally, it's not recommended to hold any non-steroidal anti-inflammatory med because shouldn't really affect it, and it doesn't really make sense why it would have, but they thought it did. There is some logic that the drug gets in through some receptors located in the kidneys and other areas of the body, or the bug, the virus. That's how it gets into the body, and so that this group of medications could possibly interfere with that. Again, that was a little bit of a stretch, and it's mostly thought to be false at this time. Same thing was thought for a couple blood pressure medications, which we'll talk about in a few weeks. ACE inhibitors and angiotensin receptor blockers are really common antihypertensive meds, and it's recommended just to keep these going, and possibly that the ARBs might actually have some benefit, but that's really unknown at this point. And then there's hydroxychloroquine, which I think everyone knows about. I actually had my wife's uncle jokingly asked me if I could get him some the other day, and I was like, "What are you talking about? You want that?" But this was one of those medications that in the very beginning, there was some promise. There were some early studies that were showing maybe some good results. But the more of those studies were looked at, they weren't the best studies, and studies that were better randomized, more controlled, that came out later basically showed that hydroxychloroquine doesn't really have any benefit. It's been looked at both for prevention of COVID and treatment. So, for example, the U of M did a study with healthcare professionals and randomized them into hydroxychloroquine or placebo arm, and then looked at how many of those people actually got COVID, controlling for other variables, and it was about the same in both groups. So it's not thought to be of any benefit, really, treatment. There is risk taking it. It's not the cleanest drug. There are some side effects. I think that the media kind of overblew the toxicity of this drug, though, a little bit. Yes, it's quite toxic, but you have to take a lot of it. Like, I'm talking 5 to 10 times the dose to really have significant toxicity with it. Otherwise, it's a relatively well tolerated med. Sure, it's got some side effects with it, but I don't want to make it sound like it's perfect. But I think there was some overblowing on that end where somebody in Arizona, I think, bought some like plant grade, or I don't know, fish food type stuff that had this in it and overdosed and died on it. And it's like, well, that's a very extreme example of what not to do. But the prescribed product, the pills, are relatively safe when taken at the doses recommended. So anyway, there is, again, so my point in that is there's a little bit of a risk there from side effects and possible sensitivities, but for the most part, it's a fairly well-tolerated medication, but we just found that it doesn't really work for this. So why give somebody a drug that's not going to make anything better? And that's the crux of the problem here, and the debate that's going on between the scientific community and other individuals. So that's all I'll say about that. Vaccines we will cover more in depth during pediatrics. The CDC website is the end-all be-all for vaccines. It's got great schedules. It's got anything you could imagine. So you have a patient who is, I don't know, an immigrant from Honduras, and they don't have any vaccine history, and they're 8 years old. What do you give them, and where do you start? Well, the CDC guidelines will tell you exactly what you should do in those situations. So they're very helpful, and that's where I would direct you to if you have any vaccine questions. Overall, vaccines cover a number of viral illnesses and a couple of bacterial illnesses as well. There are live vaccines that I talked about earlier when I referenced the nasal influenza vaccine. The only other major live vaccines that we use on a regular basis are varicella and zoster, so our HSV vaccines, and then MMR. Those are all live, so those are meds that we aren't going to give for immunocompromised or pregnant patients. So that's where it comes down to. You might hear people say things like, well, I believe I can get herd immunity from other people. I don't want to get the vaccine myself, or I don't want to vaccinate my kids because they don't need it. Well, some people actually can't get these vaccines. So like if you have a child who has a childhood leukemia or something like that, they might be too immunocompromised to qualify for the MMR vaccine. And so because you've chosen potentially not to give not you guys, because you guys wouldn't do this ever, but let's say somebody chooses to not give their child MMR vaccine, they could spread it asymptomatically to this immunocompromised child because that child can't get the vaccine. So that's where herd immunity is critical. We have to rely on it to protect people like that child with leukemia because they can't get that vaccine. The anti-vaccine movement is an atrocious attack on science, and it drives me crazy. I fortunately don't think there's that many people that actually agree with it, but they're certainly out there and they're loud about their opinions. And there's some celebrities that kind of jump on and off the bandwagon over time. So overall, you have a significant splash in the media and a significant damage to vaccines' reputation because of some of this. everything from autism to the mercury and the vaccines and everything like that. There's no studies that are out there, and they've actually looked at this, probably spent more money on this than anyone ever should have, to prove definitively that every single study that's come out that's looked at vaccines related to any type of some sort of neurogenic related disability or autism or anything like that have all come back to be negative. So that there's no correlation, there's no risk. Vaccinate away. Certainly follow the guidelines and make sure you aren't vaccinating the wrong people or people who are immunocompromised or whatnot. But certainly there's no general risk with vaccines from that perspective. The only real risk with vaccination is an anaphylaxis response. So having some sort of immune system response to the actual vaccine is always a risk. That's a risk with anything we do, any food we eat that's new, any medicine we take that's new. There's always that risk the body's going to react, and we just don't know. We can prevent that. Or we can prevent that if we do know. If we don't, we have to react appropriately. So having access to things like antihistamines and epinephrine, and we'll talk about those in a few lectures here. But all right, that's all I've got for antivirals. Again, I'm hoping to get George to give you some HIV and hepatitis related insight recorded at some point this semester. I'll touch base with you, and again, that won't be testable material. So there'll be nothing on the test regarding HIV or Hep C or any of the hepatitis, I should say. And for this test or for this content I covered today, basically anything's fair game with the exception of the few drugs that I told you not to remember, like some of the more broad spectrum anti-HSV drugs, some of the older medications like amantadine used for influenza. All right, that's all I've got for you this week.